This is Module 9, non-cardiac, non-vascular CT angiography. Although in the previous modules we have focused on looking at the heart, coronary bypass grafts, and cardiac anatomy, it's important to appreciate that these high-resolution heart scans are also high-resolution contrast CT examinations of the chest. This has been realized by the American College of Cardiology for some time, and in the original Task Force 12 in 2006 and the subsequent Task Force 13 published in 2008, it was stated, to this end, it is felt that Level 2 and Level 3 training should include review of all cardiac CT for non-cardiac findings. Here's an example of a non-cardiac finding in a patient referred for cardiac CT. This is a 55-year-old man who has a remote history of smoking and is presented to his physician with mild atypical chest pain. It was determined that a CT coronary arteriogram would be an appropriate examination. Here is a cross-section at the base of the heart in this particular patient, but evaluating the entire cross-section of the chest. This is displayed in what is called lung windows, which sets the window and level settings such that we can visualize the pulmonary vessels to maximum benefit. As we move down the tomographic images, we notice that there is a right upper lobe soft tissue mass of a particular size, which is singular in character. Its overall density is very similar to standard soft tissue and measures approximately 17 by 21 millimeters. Subsequent review of the cardiac CT showed non-obstructive coronary disease, but referral of the patient because of the abnormality in the chest ultimately produced the diagnosis of stage 1 primary bronchogenic carcinoma with negative lymph nodes and no evidence for distant metastases. A primary lobectomy was performed and the patient was considered an operative cure. Here's another example of non-cardiac findings in a standard cardiac CT examination. This is a limited field of view but a high-resolution CTA demonstrating again information at the base of the heart slightly above the takeoff of the coronary arteries. The aortic root is well opacified, and behind that, somewhat to the left side, is the normal size thoracic aorta. As you look at this examination, do you see any particular areas of concern? In particular, what about these two faint opacifications? These turn out to be enlarged paratracheal lymph nodes, approximately a centimeter in size. This is about twice the upper limits of normal for otherwise unremarkable paratracheal lymph nodes. If we take that same level but expand the field of view to include the entire chest, you can also see that there are some abnormalities in the peripheral pleural surfaces, which are of some concern. But slightly above this area, more cephalad, you can see a clear soft tissue mass, which was ultimately discovered to be a metastatic lung cancer. Most findings, though, on cardiac CT are what we call nuisance diagnoses. That is, mild abnormalities that likely do not represent any significant pathology but may or may not require follow-up. The most common incidental finding in chest CT is a non-calcified lung nodule. Now, in order to review that image, you must take the standard image used to evaluate the heart and view in lung windows. This sets the window and level settings such that we have maximum identification of the pulmonary parenchyma. As we move down in this particular area, you'll notice in the upper right area a nodule. It measures approximately 4.8 millimeters in size. This is the only nodule found, and otherwise the chest examination is unremarkable. What do we do with these nodules? There are well-published guidelines, primarily from the Fleischner Society, for disposition of pulmonary nodules. These are divided into characteristics of overall size, less than 4 millimeters up to greater than 8 millimeters, and also risk. A low-risk patient would have minimal or absent history of smoking and no other known risk factors for lung carcinoma. A high-risk patient would be one who has a history of recent or significant smoking and or any other risk factors for lung carcinoma. So if we had an individual with a 3 millimeter nodule who had no evidence of any risk for lung cancer, no follow-up would be needed. Where if that patient were a high-risk individual, follow-up would be suggested in 12 months. The larger the nodule, the more closer the follow-up. Once it gets greater than 8 millimeters, follow-up is suggested to be much more frequently, and some advocate a dynamic contrast enhanced CT to look at the nodules, a PET scan, and in some cases a biopsy. Let's try to put this all together then. Let me remind you what a normal lung window looks like. This individual on the left has a number of calcified nodules in the lung surfaces, but importantly you can see very nicely that the pulmonary parenchyma or blood vessels go all the way out to the periphery. Now let's look at the case here. This is a 35-year-old woman who presents with shortness of breath. It was determined to do a contrast CT of the chest and the coronary arteries. In this particular situation, looking at lung windows, you can see that there is clear pruning of the peripheral pulmonary vessels. This is a classic finding in pulmonary hypertension. In looking at the subsequent cardiac images on a single MIP image at the mid-chest, you can see that the right atrium is significantly dilated, that the left ventricle is not enlarged but has a flattened interventricular septum, that the left atrium is of normal size, and that the right ventricular chamber is normal, but there is significant right ventricular hypertrophy. When we then look at the coronary arteries, we find that our arteries are totally normal. So putting together the characteristics of clear pulmonary hypertension using classic findings and evidence of D-shaped interventricular septum, RA enlargement, and right ventricular hypertrophy, a presumptive diagnosis is obtained indicating likely primary pulmonary hypertension.